last presentation by Dr. Swapna Nair, pupil posers in flax, and I really was wondering what this is.
Thank you, ma'am. Thank you for having me here. And I'd like to thank both Dr. Namrata Sharma as well as the EOS for having me here. So this is nothing out of the blue. It's just what we usually face when we do have, when you're doing flags and your pupil is not exactly the ideal situation for.
Swapna slideshow, yeah.
Yeah. So is it a
slide?
Yeah,
we can see now. Yeah.
Okay. So now there are two junctures where the people can give you trouble when you're doing flags. And one is, as usual, as in all surgeries, there could be preoperative meiosis, or during the laser or just after the laser, you can get a meiosis. So these are the two junctures that you need to deal with when you're handling flags. Now, preoperative meiosis, we are all used to by cycloplegics and by non-steroidal anti-inflammatory agents. We do keep the pupil dilated just before the surgery and try to maintain that dilatation throughout the procedure by controlling the amount of prostaglandin E2 release. Now, the same thing is applicable once the laser is done, because once the laser is done, there is release of prostaglandins into the anterior chamber, and this again constricts the pupil. So initially, when I started Femtosec in 2013, this was a very common thing, because immediately after we used to do a couple of cases together with the Femto, and then we would shift to the OT for the procedure. So that is when it was very common. Now, if you have a pupillary distortion, then you can definitely adjust the rexis accordingly. For example, over here, the pupil is small, but it is regular. So the rexis just needs to be carried on as usual. Whereas in the second case over here, you can see that the pupil is more dilated to the on the lower left, right side of the screen compared to the left. So you shift the rexis accordingly and go ahead with the procedure. So slight changes in the rexis, especially when the size is to the extent of 5 or 5.2 millimeters, does not cause any decentration as such, or doesn't affect the IOL placement. Now, in case it's a very small pupil, I think one of the best options is not to do the rexis at all. One of the options. So I'll come to another one. So you can just carry on with the incision, of course, after informing the patient. So an incision alone may be a good procedure in such a situation. Now, what if you have a small pupil, which is not very small like in the previous one? Here, I sometimes minify the rexis. So rather than from the 5.2 or 5.4 that I usually keep, I bring it down up to, let's say, 4.9 or 4.8, and sometimes even 4.5, because we know that after the procedure, the rexis increases a bit. We had a study of that nature presented in the ACRS, which got the BPOS. So that is one factor which makes sure that the rexis is not uncomfortably small. And here, the most important part is what you see in the frame along the OCT pictures, that the rexis margins have to be kept well within the pupillary margins. Even when they are too close to the pupillary margin, you have to watch out for some iris bleeds, like in this case, where it was, though the rexis margin was slightly away from the pupil, the energy was enough to disrupt a part of the iris, leading to that iris bleed. You can see in the left top of the pupil. So here, another factor is that the rexis may also not be complete, because we don't know exactly when the bleed happened, whether it interrupted, the functioning of the laser in that region, and therefore the handling of the capsule also has to be careful. You cannot just pick it out. You have to make sure that the rexis is complete before it is removed from the anterior chamber, so that you don't cause any sort of posterior capsular tears. So this is another thing that needs to be watched out for when you're minifying the rexis in a small pupil. Now, as we go ahead, what we need to note is that sometimes you can use a mechanical device to dilate the pupil pre-operatively, pre-laser procedure. So here, you need to make a Maidport incision so that you have breached the anterior chamber. And once the Malyobian ring is inserted, you can see that the pupil is uniformly dilated in all directions. And you cannot do this with iris hooks because they stick out in different directions. You cannot place the eye under the femtosecond laser. So this would ensure a well dilated pupil. But I prefer suturing the main port after the procedure so that there is no sort of leak or no sort of suction disturbance while performing the laser. And the rhexis again gets to be quite centered. So these were the cases when you had a problem before the procedure started, the laser procedure starts. Now, in case once you've done the laser and you have an intraoperative meiosis, there are a couple of points that need to be noted, a couple of points that are quite avoidable. One is the laser energy that usually nowadays is default placed. Earlier, we used to keep on experimenting, with what kind of microjoules go to what levels of, pupillary constriction. But now it's uniformly kept. Now, it also increases with increased laser duration. That means if you're performing more cylinders or more cubes on the cataract, then the amount of time for which the laser is applied inside the eye increases. And that also is a point which causes meiosis of the pupil. So you can maybe stick to some simple 6 divisions or something like that. It also increases if there is a delay between the laser treatment and your patient being wheeled into the phacoemulsification OT. So when you do a couple of laser treatments initially and then take the patient into the OT, so that delay can also cause some amount of meiosis. And of course, if the pupil margin is close to the capsulotomy, then again, there is a higher chance that because of the irritation, the pupil constricts. So again, this is managed intraoperatively when you are doing the phacoemulsification. Just before that, by using all the pharmacological methods that we so commonly know, and also mechanical pupil dilatation, both by viscoelastics as well as by hooks and rings, the rings that I mentioned before, and that have been shown by other speakers. So basically, when you are dealing with a small pupil after the laser procedure, there are 3 main things that need to be noted. One, that the rhexis that has been made, and especially the part that is near the constricted pupil, is complete and totally separate from the rest of the capsule so that you can easily pick it up without causing any sort of disturbance to the rest of the capsule. Secondly, the nuclear division, especially in a small pupil, may not be complete. It might not have gone all the way in, all the wedges may not be right, or especially the ones that are under the iris. So that needs to be separated out properly, unlike the usual scene where the wedges just come straight away into the phacotip. Secondly, you can also watch out for posterior plates so that the nuclear wedges may come out en masse rather than coming out in pieces. So all these are factors during nuclear division that need to be noted. And last but not the least, always watch out for capsular tags, especially during cortical wash. Even though you have been careful with the rhexis, there could be small tags, especially in the region where the pupil was small or constricted during the procedure. So keeping all these in mind, I think a small pupil can be easily managed and you can get perfect results with the femtorhexis if you know all the techniques of doing that. Thank you very much.
Very nice.